Big challenge. As you know, NTG diagnosis needs a heightened clinical suspicion and careful exclusion of secondary causes. So I invite Dr. Shweta K, who is a consultant at Jyotis Eye Care, Kannur, to present her topic, Understanding the Enigma, Pathophysiology of Normal Tension Glaucoma. Welcome, Dr. Shweta.
Thank you, Dr. Maya. So my topic is pathophysiology of normal tension glaucoma. So NTG is defined as a classic glaucoma damage with consistently normal intraocular pressure. So when pressure is normal, why does the nerve still die? So let's look into it. NTG is not one disease, it is a phenotype. So generally when we talk about pathophysiology, we have a multi-hit hypothesis for the normal tension glaucoma. So they can be mechanical stress, they can be vascular dysregulation and neurodegeneration. So talking about the mechanical theory, it is not the absolute IOP that matters, it's the nerve's ability to withstand it. Generally it's seen that thin corneas have fragile lamina. So this lamina cribrosa where we have pores through which the optic nerve axons pass through, in NTG, it is little fragile, and that's why the even in normal IOP, it is not able to withstand, and there occurs glaucomatous damage and increased cupping. So through OCT imaging, it is seen that in normal tension glaucoma, there will be increased posterior bowing, thinning of lamina, and more posterior insertion of the lamina cribrosa. So whenever there is a mechanical stress, there occurs a blocked axonal transport and altered blood flow. Second is the vascular dysregulation theory. So what happens is whenever we have a systemic hypotension, we expect the blood supply, the blood vessels there to have an auto regulation. That is, this blood vessel has to dilate for the blood to flow well so that the nerve can have the nutrients. But in normal tension glaucoma group, there occurs auto regulation failure, and this causes increased damage, and even the cold induced vasospasm, the nocturnal dips in IOP, these are the causes which causes increase in this damage. And the perfusion pressure, we have something called a mean ocular perfusion pressure. Mean ocular perfusion pressure is measured as 2/3 of the mean arterial pressure, which the mean arterial minus IOP. So mean arterial pressure is the diastolic blood pressure minus 1/3 of the difference between systolic and diastolic blood pressure. So whenever the mean arterial, whenever the IUP is normal and the mean arterial pressure is reduced, there occurs reduce in mean ocular perfusion pressure. So this causes more stress in the axons. So when the intraocular pressure is normal and the arterial pressure is coming down, that there occurs reduced in OPP. So as I said, this occurs as a visual cycle. Every night, normal people also can have a low BP during the sleep. But what happens is when there is a decreased BP, autoregulation happens and increase in the blood flow happens. But in case of these patients, different phenotype patients, they because of the autoregulation, low ocular blood flow happens. So the systemic clues which we should see is look at the hypotension, nocturnal dips, the migraine history, the sleep apnea and thyroid abnormalities. And there is a third component, that is a neurodegenerative component. In this, whenever there occurs a lamina strain, the axons, the retinal ganglion cells, retinal ganglion cell axons form the nerve fiber layer. So there occurs blocked axonal transport, and this damages the axons. And once the RGC axons get damaged, oxidative stress, that is these dying RGCs release the glutamate. This glutamate creates an oxidative stress. Neighboring RGCs are also overstimulated and they also get damaged. And then glial activation happens. The microglial cells, these helper cells, they turn against their own neurons. So this is why we look into more of a neuroprotection, the oxidative, how do we exactly treat NTG. When we think about all this, we have to think about oxidative stress and this neuroprotection. And in NTG, whenever there is a disc hemorrhage, this is a red flag. Why does this disc hemorrhage happen? This can also be because of the vascular dysregulation. So when you see this, you always reassess everything. So, when asked about what matters more in the normal tension glaucoma, you cannot say any one point. You have to think about all the different puzzle pieces and then look at it. And clinical takeaways are: you have to identify the phenotype, check the perfusion, evaluate the nighttime BP, closely monitor, and finally IOP still matters, because when we reduce the IOP, it reduces the mechanical pressure, which the first point which I spoke about. So NTG is a structural fragility with a vascular instability with a neurodegenerative susceptibility. IOP is just one piece of the enigma. The challenge is to understand the patient, what exactly is going on with the patient, and then treat. Thank you.
Thank you, Dr. Shweta, for that nice talk. And now I invite Dr. Maya TJ, who is a glaucoma consultant in Little Flower Hospital, Angamali. She'll be discussing Seeing the Unseen, Clinical Clues and Diagnostic Strategies. Over to you, Maya.
I'll be presenting on seeing the unseen, clinical clues, and diagnostic strategies of normal tension glaucoma. I'll be explaining in this format. Normal tension glaucoma has all the features of a primary open angle glaucoma with optic nerve head cupping, corresponding visual field loss, but mean intraocular pressure consistently equal to or less than 21 millimeters of mercury. Take a careful proper history. Patient usually presents at an elderly age. If the patient is presenting at an age less than 50 years with atypical findings, we have to think of the masquerades of normal tension glaucoma. Ask for a history of vasospastic diseases like migraine, Raynaud's phenomenon, autoimmune diseases like multiple sclerosis, sarcoidosis, and if the patient is taking a night dose of hypertensive, you can expect to have a nocturnal hypotension. You can ask the history for that. History of previous retinal vascular occlusion should also be made out, as this can cause one-time damage to the optic nerve head, which could look similar to that of a glaucomatous optic disc. Also, ask for history of glaucoma and blindness in the family, as you can get an idea about the progression of the disease. Carefully probe the patient's history for possible elevated intraocular pressure in their past, like history of ocular trauma, hypema, prior steroid use, or prior vitreoretinal surgery. History of severe hypotension or shock. Ask the patient for history of surgery, trauma, sepsis, prolonged ICU admissions, or any need for blood transfusion. Obstructive sleep apnea is also hypothesized to alter optic nerve perfusion pressure. So you can ask for history of snoring at night with daytime somnolence. Ask whether patient does yoga positions, which need to be held for extended periods, that position the eye below the level of the body. It could also reduce the ocular perfusion pressure. So clinically, the patient can present as an asymptomatic non-progressive disease, which is usually picked up by an ophthalmologist during routine checkup, or as a moderate to advanced disease. Even in moderate diseases, if it is unilateral, patient may remain asymptomatic with negative scotoma. Patient may have reduced contrast sensitivity and glare, or the patient can present with an advanced disease who appreciates the visual field loss. Like primary open angle glaucoma, these patients are asymptomatic until late in the disease course. Unfortunately, these patients are undetected by intraocular pressure testing that may pick up patients with early primary open angle glaucoma. But the paracentral field loss may make the patient symptomatic earlier. Coming to clinical features, you can get a relative apparent pupillary defect, though it may not be present in the early or asymmetrical diseases. Color vision is usually preserved except in advanced disease. Reduced central corneal thickness is associated with progression risk. Do a proper slit-lamp examination to rule out the secondary causes. Like you can find intermittent peripheral anterior in cases of previous history of uveitis. You can find Krukenberg's spindle or St. Mary's line. Thus, you can come to a diagnosis of pigment dispersion syndrome. Then, by definition, intraocular pressure is in normal range, but intraocular pressures are still important. In eyes with asymmetric disease, there is more damage in the eye with higher pressure. The collaborative normal tension glaucoma study demonstrated that lowering the intraocular pressure is effective in decreasing the risk of progression. In the Baltimore eye study, half of the primary open angle glaucoma patients had intraocular pressures less than 21 millimeters of mercury at initial examination itself. Then, with apparently controlled intraocular pressures measured in the office hours, you can go for an IOP phasing, which can help demonstrate an IOP mechanism in patients with rapidly progressive disease. Usually they have a more than normal diurnal variation, which has a peak at early morning. Coming to gonioscopy, which is essential in all glaucoma patients, it helps to determine an open iridocorneal angle status and to exclude secondary glaucoma causes. You can find intermittent angle closures, old pigment dispersion syndrome. This figure, the first one shows increased pigmentation in the reduced pigmentation in the inferior in the superior angle compared to the reduced pigmentation in the inferior angle. That is, there is reversal of pigment dispersion. Usually you have more pigmentation in the inferior angle compared to the superior one. But in a burned out pigment dispersion syndrome, you can find the reversal. Then careful optic nerve examination should be done. Usually, more frequently, you can get a focal notch of neuroretinal rim than you find in the higher pressure glaucomas. Other glaucoma findings are also found, like enlargement of the cup to disc ratio, which can be focal notch, retinal nerve fiber layer defects, or concentric defects like excavation or senile sclerotic disc. Disc pallor occurs in advanced disease. The first two pictures shows inferior notch and inferior neuroretinal rim thinning, and the third one shows a superior notch, neuroretinal NRR notch, with a disc hemorrhage with a slit-like RNFL defect. Then disc hemorrhages are more frequent in normal tension glaucoma. Otherwise, for dance hemorrhages, they are typically small flame-shaped hemorrhages at the disc margin in superior or inferior quadrant. It is often interpreted as a marker of disease progression, which you can find in the first, as you can find in the first picture. You can get an evident disc hemorrhage, and in the second picture, you have to look carefully for a disc hemorrhage, which is very subtle. So in such situations, serial fundoscopic or disc photographs will help you. This first picture shows a normal, second picture shows a disc hemorrhage, which when compared to the previous one, you can pick it up easily. Then you should do a careful optic nerve examination to rule out the congenital optic nerve diseases, optic pit or optic nerve drusen. This picture shows an optic nerve drusen. Then coming to optical coherence tomography, here in the fundus photo you can find the temporal thinning, which is picked up by the OCT. Then you can find the RNFL defects also in the RNFL deviation map, and you can find a corresponding visual field defect involving the center. Visual fields, when compared to other glaucomas, they are more frequently steeper, deeper, and closer to fixation, as you can find in the picture given above. Is more localized than in primary open angle glaucoma. Then usually the superior hemifield is more frequently affected. In this picture, you can see an inferior nerve fiber, inferior neuroretinal rim thinning with a corresponding superior hemifield defect. Then the red flags include younger age or patients without a family history, rapid progression, unilateral disease, associated features like proptosis, other neurological symptoms, atypical findings like disc pallor. In these patients, you have to go for an MRI to evaluate the potential compressive lesion and to assess for ischemic optic neuropathy. Other testing measures are diurnal variation, 24-hour monitoring, BP monitoring, blood tests to rule out the secondary causes like vitamin B12. Proper cardiac evaluation should be done. Then many other features can be misdiagnosed as NTZ, like physiological disc cupping, myopic fundus disc drusen, optic disc pick, and other toxic and inflammatory causes also. So this one is a non-arthritic ischemic optic neuropathy, which is a remote one. In this, you can find the visual field defects and the corresponding superior thinning in the OCT, but there is no cupping. More pallor is present in the superior part of the disc, which corresponds to the non-arthritic ischemic optic neuropathy. Then you have to find, it is a diagnosis of exclusion. You should exclude all other types of glaucomas. So when all the features consistent with glaucoma, along with intraocular pressure less than or equal to 21 millimeters of mercury, then you have to rule out the secondary causes, and if any atypical findings are present, then you have to investigate further. You have to image the patient. Never be hesitant to image a patient if you find an atypical findings in glaucoma.
Thank you, Dr. Maya. Now I invite Dr. Abhilash Nair, sir, who is a glaucoma consultant in Giridhar Eye Institute, Kochi. He will be talking on beyond intraocular pressure, risk factor identification and management. Over to you, sir.
At the outset, I'd like to thank Maya and the team for inviting me. Now, all these talks on NTG are going to overlap a lot. So, regarding management, I'll leave it to the next speaker because that's what the main topic there is. So, as mentioned earlier by my previous speakers, it's basically a primary open angle glaucoma. So, make sure the angles are open. You should not miss a primary angle closure glaucoma as an NTG just because you don't do a proper gonioscopy. And IOP should consistently be within the normal range. So this is an office DVT, and you can see that there is fluctuations and it's consistently below 20 millimeters of mercury. So regarding the pathogenesis, regarding mainly the open angle glaucoma, that's mostly got to do with the eye problems, whether it is mechanical, vascular, or neurodegenerative. Basically eye related issues, while in normal tension glaucoma the risk factors are more of systemic risk factors. What is not NTG? That is very important. It could be a glaucoma that was active earlier, but that has now burnt out, like probably a steroid induced response that was there earlier. Now there is no steroid induced response. So the IOP has come back to normal. It could be a pigmentary glaucoma as mentioned earlier. It could be an event of blood loss which appeared, which happened during an accident. It could be eclampsia that is causing neuronal rim changes. So all these you have to rule out, because there also the IOP will be normal. You will get notching, you will get field changes, you will get everything will be correlating to a glaucoma. Your RNFL, your GCL, everything will be telling it is glaucoma, but it is a burnt out stage. It is not going to progress. So demonstrating progression is more essential when you are dealing with normal tension glaucomas, because most glaucomas won't progress in the normal tension range. It could be dysplastic optic nerve, optic nerve pathway compression, or even other neurological CNS pathway disorders. Imaging, as Maya mentioned, is very, very important. Ischemic optic neuropathy also Dr. Maya has referred to. So, what are the factors that are now, related, or which we know can cause normal tension glaucoma? One is decreased optic nerve perfusion, as Shweta mentioned. Low CSF pressure is one thing. Lamina cribrosa abnormalities and predisposition to apoptosis. Risk factors, there are numerous risk factors. Most of them, they are similar to open angle glaucomas. Old age, family history, low central corneal thickness, myopia, female gender. Female gender probably because of the vascular abnormalities which are more common in female gender. Obstructive sleep apnea, neurodegenerative diseases, the translaminar pressure difference. Now that's a very controversial thing, but that has been demonstrated to cause progression of glaucoma. I'll come to that later. Nocturnal hypotension, primary vascular dysregulation syndrome. This syndrome has been developed, found out recently only, Flammer syndrome. And genetics. Genetics we will also come to. Now, genetic studies are becoming more and more common as far as pediatric cases are concerned. And many genetic abnormalities have been discovered with relation to NTG, the optineurin tank binding kinase. These are involved in innate autoimmune functions. So they cause, when they go wrong, they cause an predisposition to apoptosis. Myocillin gene, all these are associated with NTG, more common in NTG patients than otherwise. Disc and NTG is very important. Disc hemorrhage, Dr. Maya was mentioning. Now, myopes with small disc. If you see a myope, you usually expect a larger disc. Large disc, maybe dysplastic disc, lots of peripapillary atrophy. You can't find out where the edge of the NRR is. But myopes with small discs, now that is probably, you have to be alert to NTG. Disc tilt. Now, tilt is one edge of the disc being deeper than the other edge. Disc torsion is the upper pole torting, either usually it is going to tort temporarily. So these discs are more prone for NTG. And thin lamina cribrosa. How do you find a thin lamina cribrosa? You can do an EDI, extended depth imaging on OCT. You can find out theoretically, but you need the software also. So probably not easy to find out. Now, lamina cribrosa, yes, thinner the lamina, the larger the lamina causes greater stress. And when there is greater stress at the lamina, the neural rim, it becomes weak. It is more there in myopes of African descent, and thinner parts of the lamina are more prone for damage. Thinner parts of the lamina are the superior and inferior parts. Coming to vascular abnormalities, the nocturnal hypotension is very well documented to cause NTG. Vasospastic disorders, Raynaud's, migraine. Dysregulation syndrome may be systemic, that is the Flammer syndrome, or could be local, that is just the ophthalmic artery that is involved. Reduced blood flow may be retrobulbar or cerebral, the internal carotid, and cerebral microinfarcts are also associated with NTG. Can you measure ocular blood flow? You can measure ocular blood flow. Whether we do it frequently? No, we don't do it frequently. You will have to refer to some other institute to do that. So, not a practical way to treat. But if your glaucoma is progressing and your IOP is very low and you don't know what else to do, then first you have to do imaging. You may have to refer for cardiovascular evaluation and do all these studies so that you can find out other risk factors which may also impact the patient in other ways rather than not just the glaucoma part, the increased mortality due to cardiovascular diseases and all. Of course, visual field loss will correlate with the ocular blood flow, and decreased peripapillary capillary density you can measure with the OCTA, OCT OCTA. Fluctuations in ocular perfusion pressure, Dr. Shweta was mentioning, unstable oxygen supply, fluctuations in the BP, reperfusion injury, oxidative stress, apoptosis. It's a vicious cycle. It keeps on, going down. Retinal venous pressure. Retinal venous pressure was not given the initial, it was not thought to be very important. But it has been found that retinal venous pressure increases in patients with NTG. There is vascular dysregulation, increase in endothelin and homocysteine. This is Flammer syndrome, usually seen in young ladies. The physically they'll be slender, cold hands and feet, low BP, extreme sensitivity to temperature. Circadian rhythm is usually shifted. They sleep very late at night. They can't sleep properly and they sleep more in the morning. Instability of the ocular blood flow and the ocular perfusion pressure has been seen. L-methyl folate is supposed to improve the condition. Nocturnal sleep apnea, impaired CSF, decreased CSF pressure. These are all studies which showed that patients with decreased intracranial pressure are more prone for NTG. Now, how do you measure the pressure? You have to measure the pressure in a lateral decubitus position. Whether that is the pressure in the optic nerve sheath is another moot point, because our optic nerve sheath has fenestrations that keep the pressure around the optic nerve constant compared to the intracranial pressure, which varies very much when you change position. But still, decrease in intracranial pressure has been shown to increase the NTG. So lots of studies based on that. Now the other question is, can lowering the intracranial pressure cause NTG? So there's a study on that also, which was it was published in Journal of Neurosurgery. So they followed up patients for many decades who had undergone transperitoneal shunt for hydrocephalus, and they found out that these patients develop symptoms similar to NTG. So definitely ICT has a correlation with NTG. Sorry, just one more. So obstructive sleep apnea, the symptoms: loud snoring, apneic smells, daytime drowsiness, headache. They are more prone for cardiovascular disorders and type 2 DM. This is the stop bank questionnaire for obstructive sleep apnea. If you have a value less more than 5, that means it's high risk. You have to send for sleep study and respiratory medicine consultation. Thank you.
Thank you, Dr. Abhilash, for that enlightening speech. Now I invite Dr. Smita VK, consultant, Little Flower Hospital, Ankamali, for her talk on tailored therapy, treatment approaches in normal tension glaucoma. Over to you, ma'am.
Good morning, all. My topic is tailored therapy, treatment approaches in normal tension glaucoma. IOP lowering remains the mainstay of treatment in controlling NTG. It includes medications, laser, and surgery. Collaborating normal tension glaucoma study randomized patients to observation versus treatment group, and 30% IOP reduction reduced the progression in treatment group. Medication remains the mainstay of treatment. Prostaglandins have high efficacy. It controls 24-hour IOP and reduces the. It has best IOP lowering capabilities and it has a good safety profile. It can be used once daily and it has a neuroprotective effect on the retinal ganglion cells in animal models. Beta blockers better to avoid as it can cause nocturnal hypotension and nighttime IOP reduction is less. It should be used cautiously in bronchial asthma and bradycardia. Carbonic anhydrase inhibitors reduce aqueous production. It can have 15 to 20% IOP reduction. It can cause ocular blood flow, increase in ocular blood flow. Rho kinase inhibitors like netacidil and ripacidil improves the trabecular outflow, decreases the aqueous production and decreases the episcleral venous pressure. It increases the optic nerve head blood flow via vasodilatation, and it has a neuroprotective effect through the modulation of retinal ganglion cell apoptosis in animal model. Brimonidine is an alpha-2 agonist which decreases the aqueous production and increases the aqueous outflow. Low pressure glaucoma treatment study randomized patients to brimonidine group and timolol group, and patients treated with brimonidine were less likely to show visual loss progression compared to those receiving timolol, despite similar IOP reductions. It suggests a neuroprotective effect of brimonidine. Brimonidine inhibits the apoptosis of retinal ganglion cells in animal models through the upregulation of brain-derived neurotrophic factor. Selective laser trabeculoplasty is a non-invasive procedure. It can be done in cases when the patients are non-compliant or intolerant to medication. It may decrease the IOP about 2 to 3 millimeters. A 2-year clinical results after selective laser trabeculoplasty for normal tension glaucoma showed that 11% of eyes no longer required medications after 2 years. Surgery can bring the IOP to a single digit. Trabeculectomy can be done when the normal tension glaucoma progresses in spite of medication. The target IOP is often lower in normal tension glaucoma, so patients are at risk of hypotony, and there is 24-hour IOP control, so progression is less in after trabeculectomy. Microincision glaucoma surgery can be combined with cataract extraction. It can reduce the number of drops to be used, but it's difficult to obtain the IOP below the episcleral venous pressure. So, collaborative normal tension glaucoma study showed that in spite of 30% IOP reduction, 12% of patients progressed, and in the early manifest glaucoma trial, in spite of 25% reduction in IOP, 55% of patients progressed. This suggests that factors other than IOP has role in the NTG, and so neuroprotection has a role in treatment of normal tension glaucoma. Retinal ganglion cell death occurs when there is a mechanical pressure at lamina or when there is ischemia or genetic factors which can lead to obstruction of the exoplasmic flow and depletion of neurotropic factors which can lead to disruption of mitochondria, or otherwise there is glial cell activation in the retina and lamina cribrosa which causes release of neurotoxins, and there is excess glutamate which leads to NMDA receptor activation, and there is excess inflow of calcium into the cell leading to disruption of the mitochondria and production of caspases, which leads to retinal ganglion cell apoptosis and there is a neighbor killing effect resulting in secondary damage to the other retinal ganglion cells. Neuroprotection refers to any treatment intervention that is used to prevent the retinal ganglion cell death. Current approach is to strategies to improve the optic nerve head perfusion, rescuing the damaged retinal ganglion cell, and optic nerve regeneration. Agents to improve optic nerve head perfusion include carbonic anhydrase inhibitors, ROCK inhibitors, and calcium channel blockers like nimodipine, lomeracin, and flunarizine. Rescuing the damaged retinal ganglion cells by neurotrophins. Neurotrophins are important for the cell survival and repair, and it can be done by application of exogenous neurotrophic factors like brain-derived neurotrophic factor, ciliary neurotrophic factors, etc., or strategies for sustained endogenous expression of injected growth factors like transfection of this growth factor genes into retinal ganglion cells via viral vector, and stimulation of retinal ganglion cells with electrical activity. This ciliary neurotrophic factor can be injected into the pars plana. It provides neurotrophins and it is under the clinical trial. NMDA antagonist targets the excess glutamate, which can cause neuronal toxicity. This excess glutamate increases the intracellular calcium, which leads to a series of events leading to retinal ganglion cell apoptosis. Memantine is an NMDA receptor antagonist. It selectively blocks the excess open channels. There is an ongoing research on formulations of memantine encapsulated nanoparticles. Antioxidants like ginkgo biloba extract is a phytochemical used in the treatment of cognitive disorders. Is under clinical trial for glaucoma. And resveratrol is a phytochemical which is thought to increase the blood flow to the brain. Is also under currently under research. And optic nerve regeneration can be done by blocking the inhibitory signals and by improving the intrinsic cell growth ability and stem cell regeneration. Blocking the inhibitory signals can be done by the glial tissue release the inhibitory molecules that signal retinal ganglion cells to stop growing. Cetrin is a ROCK inhibitor. It inhibits the signaling pathways that mediate the stop signals. It could be tested for optic nerve regeneration. Enhancing the intrinsic growth ability by gene therapy based approach to target the transcription factors. Genetic therapy to overexpress the brain derived neurotrophic factor and this receptor have enhanced the retinal ganglion cell survival. Stem cell transplantation enhanced the retinal ganglion survival when injected intraocularly in animal models. Challenge is to transform the injected cells into retinal ganglion cell phenotype. Mesenchymal human embryonic stem cells are under research now. Systemic management. NTG involves vascular and perfusion pressure issues beyond IOP, so avoid nocturnal hypertension. If using antihypertensives, have to address the sleep apnea, migraine, and Raynaud's phenomenon. Lifestyle modifications, stop smoking, regular exercise, avoid certain yoga postures and breath holding, avoid lateral decubitus position in asymmetric glaucoma. In conclusion, IOP lowering remains the primary treatment for NTG, and ideal NTG treatment should target both IOP and IOP independent risk factors. Neuroprotection to attenuate the retinal ganglion cell death is the future. Thank you.
Thank you, Dr. Smita, for that informative talk. Now I invite Dr. Manju M., glaucoma consultant at Arya Eye Care Thrissur, for delivering her talk on monitoring progression, visual field, and structural surveillance. Over to you.
Thank you, Dr. Maya, for this opportunity. Monitoring progression, visual field, and structural surveillance in normal tension glaucoma. So, what is progression in NTG? The progression in NTG refers to identifying the worsening of structural or functional damage to the optic nerve over time despite normal intraocular pressure. So, why is it important? It's important because progression can occur despite normal intraocular pressure, and there can be subtle structural changes that precede functional loss, And the therapy should be, a treatment should be tailored based on the progression. The treatment modifications can be done based on progression, and there can be variable and asymmetric progression. There can be variation between the eyes and between patients, and all rate of progression can be varied. So it's important to monitor progression. So there are two things. One is structural progression, which is monitored as changes in the optic nerve head cupping, changes in the optic nerve head, like increase in cupping, thinning of the retinal nerve fiber layer, or and the ganglion cell complex, and there can be localized defects in the lamina cribrosa. And functional progression, which is measured by deepening of the existing scotoma, or enlargement of the existing scotoma, or appearance of a new scotoma. These are the factors that tells you about the functional progression. So structural progression, as you know, this monitor. Why is it important? Because structural changes in NTG especially can precede functional loss. There is quantitative measurements via OCT allow us to accurate tracking over time, and it's very essential in NTG and pre-perimetric glaucomas. And progression on OCT may prompt treatment modification in patients with unreliable visual field. That's one thing. If the patient is having an unreliable visual field, is important and can help you in the clinical decision making. So this is the OCT analysis usually done in glaucoma. And first, always check for the signal strength. Anything more than 6 is acceptable. Centration of the disc should be checked and see for any artifacts. And there is an RNFL thickness map. This is the absolute RNFL value of the patient, and it is compared with that of the normal patient to give a RNFL deviation map that compares the cluster of pixels with that of the normative database. And here is a quadrant map and a clock over map, which tells you the values of the patient in each quadrant and clock over. And there is also panomap, which combines RNFL values with that of the ganglion cell IPL complex. So it's important to monitor the macular factors of the changes in the macular factors like GCL, IPL thickness also with the progression. And this is a guided progression analysis, which tells you about the average RNFL thickness. You can get superior, inferior, nasal and all. And each values, you should have two baseline values and current values also. It's better to have all reliable OCT values, and the system will tell you how the thickness is behaving over time, whether it is decreasing, whether disease is progressing and all. So you can have a guided progression analysis. Next is the functional progression. Functional progression is measured by deepening of the scotoma, enlargement of an existing scotoma, and appearance of any new scotomas. So also there is also guided progression analysis system for functional progression. There should be minimum 5 fields, 2 reliable baseline fields around 6 months apart, and 3 follow-up field, total of a 5 field. And there's a trend analysis, which is based on the visual field index or mean deviation also, you can tell. So here the visual field index of each visit will be recorded, and the main thing is that system can extrapolate this data over next 5 years and tells you that if this patient is having the same rate of progression, what will be the patient's visual field index after 5 years. So there is a trend analysis, and it can tell you about the rate of progression also. So this patient, the patient was first visited in 2012, and 2 baseline fields are taken in 2012, and this is in 2018. And you can tell there is a steep decline in the patient's visual field index, and there is a rapid progression that is happening. And over 5 years, if the trend is like it's touching the baseline, means if the same rate of progression is happening in this patient, after 5 years, the patient is going to get blind. So this progression or this system itself tells you that you should intervene. You should either increase the medication, do a surgery or laser to improve the or to reduce the progression of the patient. That is the importance of a guided progression analysis. And this also, there is one more thing. If the same rate of progression is happening and you are intervening something, you are doing some intervention, then you should change here the patient underwent a surgery, then the baseline field should be changed, so that the next 2 fields should be taken as a new baseline field, so you get a new rate of progression. If you keep the same previous baseline field, you will have the it's a wrong rate of progression. So after any intervention, change your baseline field and see for the newer progression rate. And there is also an event-based analysis which tell you any 5 whether there is a same point, same 3 points in same 3 consecutive visit. If there is a 5% deterioration, one is a open triangle, half fill triangle, and a full fill triangle. If there is a less than 5% progression in 3 consecutive visit, and if there is a same point is having less than 5% deterioration in 2 consecutive visit, it is possible progression, and 3 consecutive visit, it is likely progression. And there should be 3 consecutive field, that is very important. And also if you see here, this compared to the baseline field, the latest field is improving, so there can be a learning effect also. So if you feel that there is a learning effect, the newer after the learning effect, that field should be taken as a baseline field so that you get a correct rate of progression. And here very advanced glaucoma 24-2 is almost touching the baseline. So in such cases, the 10-2 field should be taken as a basic field for analyzing the rate of progression in the advanced cases. And always this should be compared with that of the structural progression to get a correct, whether it is correct or not. So here this patient, there is a RNFL thinning, correspondingly there is a GCL thinning also, and this machine is telling you with this RNFL thinning where can be the field defect of the patient. So this is the area where the machine is telling you the field defect can be, and the HFA that is taken in the another machine, the patient is having field defect in the same regions. This means there is a structure function correlation. Always see whether there is a structure function correlation before taking the judgment. And here also there is a inferior thinning. The machine is telling you this is the area of probable visual field defect, and the patient is having the visual field defect in the same region. And there is NTG study that is all mentioned. So in the NTG study is the collaborative normal tension glaucoma study is the landmark study, and the risk factors that is predicting for faster progression was disc hemorrhage, female gender, and a history of a migraine. So take home messages are structural, especially in normal tension glaucoma, structural progression can precede functional loss. Central visual function is at high risk, so always possible incorporate 24-2 with 10-2 or 24-2C. Slow progression means it needs constant monitoring. It should have more structure function correlation also, and patient should have an individualized risk assessment. Thank you.
Thank you, Dr. Manju, for that informative talk. So I thank all the presenters for their talk and all others for their patient listening.